خلقناكم من ذكر وأنثى وجعلناكم شعوبا وقبائل تعارفوا إن أكرمكم عند الله أتقاكم. صدق الله العظيم. سيد وزير الصحة ولاية الخرطوم السيد محمود حميدة، السيد دكتور علاء الدين حسن أحمد يوسف رئيس جمعية اختصاصية الصدر السودانية، السيد بروفيسور جابر كبلو الأمين العام للجمعية الطبية السودانية، السادة الضيوف الكرام، الحضور الكريم، مع الاحتفاظ بمكاناتكم السامية، إخوة أطباء مصر الشقيقة، السلام عليكم ورحمة الله تعالى وبركاته. أرحب بكم في عقل داركم وفيكم. قد أتانا الربيع طلق ضاحكا من الحسن حتى كاد أن يتكلم، قد نبه النيروز في غسق الضياء أوائل ردة بالأمس نوما. أسمح فضيلة هذه اللحظات أن أقدم إليكم بحضر التهنئة والإشادة والدعوات الصالحات بمناسبة انعقاد مؤتمركم السابق، وهذا إن دل على شيء مما يدل على جهد مبذل وعمل مقبول وحضور مشمول بالأمل والعمل والرجاء. جاءوا زرافات وإحدانا من أبناء النيل في شمال الوادي ومن الشرق ومن الغرب ومن دول شقيقة ومن كل حدب وصوب يشهد هذه اللحظات الخالدة في تاريخ الطب السوداني. أعزائي أنتم الرائعون دوما، لكم موقع في الإعراب في دواخلنا، وأنتم تدعون لطفنا وخبر سعادتنا ونضافون إلى شعورنا. بركت بنا ومنا كما ابتلت جوارحنا شوقا إليكم، ولا جفت مآغينا إن الزمن الذي كان يضحكنا أنسا بفضلكم ما عاد يبكينا. الذي أقدمه للحديث لكم كان والدي وزيرا للمعارف سابقا في أوائل عهد التعليم في بلادنا، وكما قيل هذا الشبل من ذاك الأسد، وكما قيل مشى الطاووس يوما باختيال قد شكل مشيته بنوه، ينشأ ناشئ الفتيان منا على ما كان عوده أبوه. تفضل السيد دكتور علاء الدين حسن أحمد يوسف رئيس جمعية اخراج السودانية للغاية. وزير الصحة بولاية الخرطوم، الأخ البروفيسور جابر كبلو رئيس الجمعية الطبية السودانية، الحضور الكريم، السلام عليكم ورحمة الله تعالى وبركاته. بدءا ما كنت قط أود ذلك الإطراء ولم أعلم به، وإن علمته ربما غيرته. أرحب بكم في هذا المؤتمر والشكر الجزيل لكم على حضوره، وهذه تظاهرة علمية نتمنى أن نقدم فيها لكم بعض الأوراق العلمية، وكنا قد قدمنا لكم في اليومين السابقين ورش عمل كانت محظورة وكانت مفيدة، ونتمنى أن نقدم لكم بين اليوم والغد أوراقا علمية لعلكم تجدونها مفيدة تساعدكم في ممارستكم الطبية. لا أود أن أطيل عليكم، أود أن أشكر الأخ البروفيسور محمود حميدة وجابر كبلو على المساعدات التي قدموها لهذا المؤتمر، وأود أيضا أن أشكر الشركات التي قدمت مساعدة لهذا المؤتمر. وكما تعلمون فإن جمعية اختصاصي الصدر السودانية وأخصائي الصدر السودانية جزء من الجمعية الطبية السودانية، وهي الذراع العلمي لنقابة أطباء السودان، ونحن أردنا تطوير المهنة والتخصص، ونتمنى من الله أن يوفقنا في فعل ذلك. أختم حديثي هذا بأن أتحدث قليلا باللغة الإنجليزية للذين من ضيوفنا الكرام الذين لا يفهمون اللغة العربية. It gives me great pleasure to welcome the delegates from Ireland I have been talking in Arabic because it's the habit of these conferences to start talking Arabic, that I always make the point of giving a brief translation of what I said. This is a scientific conference, and I hope that over the next 2 days you will be able, for the attendees, to be able to hear some useful scientific papers that will aid you to improve your practice. And in the last 2 days, we have had 2 workshops which have been well attended, and I think they have been very extremely useful. And the aim of this society is to promote the practice of pulmonology in this country. And I think over the last year, we have been successful in this holding quite a few lectures and seminars and teaching sessions and workshops. And I hope this conference will be an addition to that. We are only half term, so we've still got 12 months to go. And I sincerely hope to see you again next year. ولا يفوتني قبل أن أترك هذه المنصة أن أشكر مركز التدريب المتطور، لا تسعني الكلمات في ذلك، فهو قد قدم لنا كل المساعدات بما فاق تصورنا من كرم وحفاوة. ولا أود أن أفيد وأذكر التفاصيل، لكن هم قد they showed at this conference and they did a lot to us. فلهم مني شكرا جزيلا. شكرا جزيلا. ذلك الرعاء الذي يضمنا جميعا، ونتمنى أن يبسط ذراعيه تعاونا وتسهيلا لكل الأطباء أن ينجحوا حقوقهم كاملة دون نقصان. الآن جاء دور بروفيسور بكر جابر تولو الأمين العام للجمعية الطبية السودانية. تفضل.
بسم الله، الحمد لله، والصلاة والسلام على رسول الله. السلام عليكم جميعا. بدءا بالأخ الكريم البروفيسور محمد علي حميد وزير الصحة بولاية الخرطوم، والأخ الكريم البروفيسور علاء الدين حسن رئيس الجمعية في الصدر السودانية، والإخوة أعضاء اللجنة التنفيذية وضيوفنا الكرام، والإخوة الإعلاميين وعلى راسهم الدكتور عوض وطبيب الصدر عمر محمود خالد. وعجبت أنهم لم يشاركوا في التقديم، لا يشاركوا أذاننا ببعض اللغة العربية وجميل القول وحسن الألفاظ، مما لعلنا نحن في هذا الصباح الطيب المبارك نحمد الله سبحانه وتعالى أننا نستقبل فتحا علميا جديدا في كل صباح. بالأمس كان المؤتمر العلمي لجمعية اختصاصية جراحة التجميل، ومن قبل كانت عدد من الجمعيات والروابط التي زادت عددها عن 33 جمعية ورابطة من التخصصات الفرعية والتخصصات الرئيسية. ولعل الأعوام التي انصرمت، ال5 أعوام التي انصرمت، شهدت طفرة في تطوير التعليم الطبي وفي نشر التخصصات الطبية وفي توطين التخصص داخل السودان. الآن تسهم هذه الجمعيات، وعلى رأسها جمعية الصدر التي هي جمعية رائدة متعاقدة الآن المؤتمر السابع، لتؤكد لنا أنها هي على ذات المنحى والسير في طريق تطوير هذا التخصص الفرعي من التخصص الذي كان في السابق هو جزء من التخصص الأمراض الباطنية. والآن أصبحت وتشعبت كما تعلمون العلوم، وتشعبت كذلك التخصصات، وانتشرت المعرفة بصورة مذهلة يصعب على الإنسان بعمره القصير أن يحيط بها. ولكن بنشر هذه المعرفة عن طريق هذه التخصصات. نحمد الله سبحانه وتعالى أن الجمعية الآن وضعت أسس المنهج الاختصاصي الصف، وقامت أيضا بإسهام كبير في تطوير التعليم الطبي المستمر في ورش العمل والمحاضرات واللقاءات العلمية المستمرة وإقامة مثل هذه المؤتمرات. وأسهمت أيضا في مجال الأخلاق الطبية والممارسة السريرية بلجان على مستوى المجلس الطبي السوداني، فكان لعضويتها الإسهام الفاعل في تأسيس وتطوير هذه المهنة عن طريق أخلاقيات المهنة ولترسيخ مفهوم التسجيل للاختصاصيين في هذا المجال. نحن أيضا سعداء إذ نرى أن لعضوية هذه الجمعية إسهام فاعل في تطوير التعليم الطبي على مستوى الجامعات للأندرجراديويت ستودنتس، وشهدنا كذلك في ظل انتشار رياضة الطب التي أصبحت تزيد على 30 كلية. نشهد الآن يعني إسهام فاعل للجمعية في تدريس طلاب الطب. أنا لا أود أن أطيل في الحديث، ولكن أتمنى لمؤتمركم هذا النجاح، وأتمنى له كذلك يعني أن يثري التجربة العلمية في مجال هذا التخصص بما هو مفيد ونافع، وأن تنشر أوراقه أيضا في الدوريات المحكمة حتى يرى العالم من حولنا هذا النتاج العلمي الذي له أثر إن شاء الله في حياة الإنسان، لا أقول في مجال أو في نطاق السودان فحسب، ولكن على مستوى العالم أجمع. It gives me great pleasure to welcome our speakers from abroad who volunteer time and effort to join us here in Sudan. And I think their mere presence is a token of good relationship and loyalty and dedication to this specialty and to medicine worldwide. And I think their mere presence, showed us with the token for a good collaboration with us and with loyalty and dedication to our people here. I think their presence will contribute a lot to the success of this conference. Thank you very much.
البحر في عشائي يبدو كان من هل سأل البحار عن صدقاتي إننا نطلب لهذه الصدقات سيد الوزير، نطلبه منك كثير وما نتمناه منك أكثر. تفضل سيد وزير الصحة، لا تخطون أكثر من
نبدأ بالترحيب والتحية للأخ رئيس الجمعية الأخ البروفيسور علاء، وعبره للإخوة المكتب التنفيذي لهذه الجمعية، والتحية للأخ الراعة من مصر الشقيقة والأخ فينسنت يونغ من آيرلند، وكل الحضور الذين سبقوا بعطائهم الثر لهذه الجمعية تأسيسا وحراكا حتى حين كان الصدر غير مرغوب فيه كتخصص. الأخ عثمان الضوي والإخوة الأخ خاتم الياس والذين أرسوا دعائم هذا التخصص الهام. نحن نشهد كما ذكر الأخ بكر جابر كولو، ونشكره شكرا جزيلا على رعايته لهذه الجمعيات، وكان سباقا في دعم هذه الجمعية وغيرها. نشهد كما قال حراكا واسعا لهذه الجمعيات. وفي العام الماضي أو العامين الماضيين تغيرت وظائف هذه الجمعيات لتصبح استشاريات في مجلس الوزراء، وزير الاتحادي والوزير الولائي كاستشاريين في تخصصاتهم، وقد انتهينا فرصة في أن نستعين برؤساء الجمعيات كمجلس دائم لوزير الصحة الولائي. الدور الكبير الذي تقوم به هذه الجمعيات بعد تحولها تحولا كبيرا إلى جمعيات تدريبية وجمعيات ضبط جودة وجمعيات تهتم بتقليل الأخطاء الطبية، هذا الدور الكبير يلقي على عاتق الإخوة الأعضاء عبئا كثيرا وكثيفا. وسررت جدا أن هنالك عدد من الورش التي أقيمت قبل قيام هذا المؤتمر، وهذا ديدا هذه الجمعيات. فنحن نطلب من الأخ جابر قبله أن ينسق لهذه الجمعيات في أن تقوم بمجال تدريبي أكثر مع انعقاد المؤتمر وبعد انعقاد المؤتمر، وربما تسجل كل جمعية كم من الورش قدمت وكم من فرص التدريب قدمت ما بين مؤتمر ومؤتمر. ونحن نعول على هذه الجمعيات لأننا نواجه بأعداد كبيرة من طلاب الطب في جميع الكليات التي تحتاج إلى تدريب، ونواجه أيضا بأعداد أكبر في الدراسات الطبية العليا، وكل هذا الجهد لا يمكن أن يقوم به إلا الأخصائيين والاستشاريين في المجالات المختلفة. هذه واحدة. الثانية، مع طرحنا للخطة الجديدة لوزارة الصحة، وأقول أنها ليست جديدة ولكنها ظلت في أطابير وزارة الصحة الاتحادية والولائية لفترة طويلة، ولكن بعد أيلولة المستشفيات سنحت السانحة أن ننفذ خطة ترضي طموح المواطنين. نحن نقول دائما أن المؤسسات الطبية والصحية هي تقوم لمصلحة المريض وليست لمصلحة العاملين في هذه المجالات. إن كانت لمستشفيات المركز وقع القدم ووقع التاريخ، فإن العاصمة والولاية قد انتشرت انتشارا واسعا حتى تبدت الخطة وتبدت الملامح الجديدة للولاية، فأصبح معظم السكان يسكنون خارج المركز. فإذا قدرنا أن سكان الغدة أكثر من 1,800,000 شخص، وسكان جبلولي منطقة جبلولي أكثر من 1,700,000 شخص، وأن 25% من أطفال الولاية 25% من أطفال الولاية يقطنون في ولاية غدة. كل هذا يحتم علينا نحن الأطباء أن نقدم أنفسنا في مكان احتياج المريض. لا تقوم المستشفيات أبدا لراحة الأطباء، لا تقوم المستشفيات أبدا لراحة الكوادر، وإنما تقوم أساسا لراحة المريض. أينما يكون المريض يكون الطبيب. هذا هو ما درسناه وهذا هو ما أقسمنا عليه. ومن هنا كان تحريك المركز إلى الأقاليم أو إلى أطراف العاصمة كان هذا ضرورة. ونحن حقيقة في كل افتتاح لهذه المؤتمرات ننادي ونناشد إخواننا من الأخصائيين خاصة في التخصصات الدقيقة أن يساعدوا الوزارة في إنفاذ هذا المشروع الكبير. المرحلة الثانية هي تقوية المراكز الصحية، ونعلم تماما أن الرعاية الصحية الأولية هي ليست بدعة لهذه الوزارة وليست بدعة للسودان، إنما بدأت عام 1978 في مؤتمر المؤتمر الذي أقر primary health care as a vital ingredient of a proper health delivery system. وحصل revitalization لهذه الفكرة في التسعينيات، والآن أصبحت حتى الدول المتقدمة تعتمد اعتمادا كبيرا على الرعاية الصحية الأولية. ماذا قدمنا في الرعاية الصحية الأولية في هذا العام والعام الماضي؟ تم افتتاح أكثر من 90 مركز جديد. ونحن عندما نتحدث عن المراكز الجديدة أعلم أن 70% منكم لم يشاهدوا مركزا جديدا لأنكم تعملون في المستشفيات، ولكن دعوتي لكم أن تزوروا المراكز الجديدة خاصة المرجعية والنموذجية منها، وتجدون شيئا آخر غير الذي عرفتموه عن المراكز الصحية. ولإنعاش هذه المراكز أقمنا شراكات بين الجامعات المختلفة وفي المستشفيات، وعلى أن يتم الإشراف على هذه المراكز بأخصائيين من الجامعات. وهذه التجربة أصبحت ناجحة تماما، إذ أن الأخصائيين من الجامعات بقاماتهم المختلفة وبدرجاتهم العلمية المختلفة يؤدون واجبا في هذه المراكز، وهذا أدى إلى ارتفاع القيمة الحقيقية لهذه المراكز. نحن لا نود أن نطيل، ولكن هنالك أمثلة كثيرة. النيلين في بشاير، أسهري في علي عبد الفتاح في الدروشاب، جامعة العلوم الطبية في الشجرة واللوز، كلية النيل في بحري. كل هذه الجامعات والكليات الطبية أصبحت لها موضع قدم بهذه المراكز. النقطة الثالثة هي تطوير المستشفيات المركزية إلى مستشفيات مرجعية. وهنا يحدو بنا القول أن مستشفى الشعب الذي كان قلبا ورئة ودماغا أصبح الآن قلبا ورئة، فانتقل المخ والأعصاب إلى إبراهيم مالك. والذين لم يشاهدوا إبراهيم مالك ندعوهم إلى مشاهدة إبراهيم مالك حتى يتكلموا عن العلم عن هذه الخطة. وبهذا فتتمدد تخصص الصدر، وأضفنا إلى تخصص القلب للأطفال. كما أن مستشفى أبو عنجة يشهد حراكا واسعا، ومعنا الأخ الدكتور كنا، وهنالك عيادة كبيرة جدا يقوم بإنشائها، عيادة خارجية. والقسم الذي تقوم به UNDP للTB المكافح أو المقاوم للأمراض سينتهي العمل في العنبر أو الجزء الخاص بهذا العلاج قبل نهاية هذا العام. كما رفدنا هذا المستشفى بمناظير للرئة إن شاء الله، وحيكون هنالك قسم لأوكيوبيشنال ثيرابي. هذا ما يعني هذه الجمعية، ونحن نطلب من الأخ رئيس الجمعية ومن الإخوة الأعضاء أن يكونوا شركاء في هذا العمل الكبير لتطوير تخصص الصدر. نحن حقيقة نعول كثيرا جدا على هذه الجمعيات. هذه الجمعيات تقوم على أساس ديمقراطي، تقوم على أساس علمي، تقوم على أساس أكاديمي. ومن هو أولى بتطوير هذا التخصص غير هذه الجمعية؟ نحن نشكر لدعوتكم هذه، ونشكر لهذا الحضور الكبير، ونشكر للCPD لاستضافة هذا المؤتمر. And I would like to thank also Professor Dr. Vincent Young and أخراج من مصر for contributing to the deliberation of this conference. وأشكركم شكرا جزيلا على حسن الاستماع.
Assalamu alaikum wa rahmatullahi wa barakatuh. Please forgive me for addressing you while I'm sitting down. It's because of physical ailment, a temporary physical ailment. I'm pleased to be with you here this morning to speak about a very important topic
which is heavily knocking on the doors of every healthcare system, health organization, and medical practitioner. That's patient safety. It's now the current issue. Is being discussed every day and night within the medical profession. The reason why I opted to choose this topic is to introduce to you the concept of patient safety, which is now the cornerstone of healthcare service. And secondly, to highlight some problems or activities related to patient safety, and finally to persuade you and myself to adopt this practice in our everyday medical practice. So the talk is really an eye opener, to open our eyes widely while addressing this issue. Error is part of human nature. There is no infallibility. And it's not a crime to commit error. But I think it's a crime not to learn from our mistakes. Having said that, we have to emphasize that this is not a reason for ignoring the fact that we have to do our utmost best to avoid errors. This was highlighted by early time ancient Romans and Greek tradition. Do no harm first. So I'm going to discuss patient safety and adverse events, and then the magnitude of the problem in the Sudan and worldwide. So what's patient safety? It's a new healthcare discipline that aims at avoidance, prevention, and amelioration of adverse outcomes or injuries stemming from the process of healthcare. The emphasis is on reporting, analysis, and prevention. So the emphasis really is prevention. Adverse events, a lot of being said these days about adverse events or الأخطاء الطبية. So what's an adverse event? It's a harmful, undesired, unintended outcome which occurred during the provision of health care, either from medication, medical intervention, or surgical intervention. The majority of these events in developing countries actually occur as a result of underlying factors concerning the health system. So patient safety should be viewed from perspective of healthcare system rather than emphasis on individual activities. And while we are developing strategies or policies, we should aim at modifying, changing, or strengthening our healthcare system, while at the same time not ignoring the part of the individual in providing a safe care, because this is crucial. Individual part in delivering a safe care is crucial and should not be ignored. Till recently, nobody was talking about patient safety. First highlighted in the 1970s, when studies revealed that about 30% of patients admitted to acute medical units and 13% patients admitted to ICU units experience adverse events. But the problem was highlighted to health policy makers and healthcare providers, mainly in the 1990s. Just 1991, by the Harvard Medical Practice Study. This study was a retrospective study conducted in 51 hospitals in New York, whereby 30,000 medical records were reviewed, and came to the conclusion that the incidence of adverse events in those hospitals was 3.7%. Now, in 1997, that was extrapolated to the whole of the United States, And the estimate then was between 44,000 and 98,000 of patients in United States hospitals die as a result of adverse events annually. That's more than the deaths resulting from road traffic accidents. And at the same year, the extrapolation in the United Kingdom estimated that about 850,000 patients annually experience adverse events. The main types are of threats to patient safety in hospital is healthcare associated infection, diagnostic mistakes, surgical mistakes, and adverse drug reactions, whether it's type 1 or type A. What's the nature of error? Error is a complex event. It's a combination of two, what we call latent factors. That's factors relating to the healthcare system, and active factors. Active factor is the most common, the most seen, the most discussed by the media and by the policymakers, because it occurs at the time or at the site where clinical expertise is applied, and that's why I call the sharp end. So usually a lot of factors, small factors, at the time not perceived as a threat, but when they accumulate together, then they end in at the sharp end. For example, a patient admitted to the accident emergency department with bleeding. The poor doctor examined the patient, secures an IV line, and he requests blood. He doesn't find the request form. The cupboard is locked. The key with somebody is not available. Then he writes the request in a normal paper, send it to the lab. The lab technician is not accepted. He wants the request to be formally written in the lab request, and so on. And this, for example, takes about half an hour, 45 minutes, blood pressure going down, shock, patient dies, then the relatives attacking the poor doctor. So this is system failure actually, rather than an individual failure. It's just an example of what's happening in healthcare organizations. Circumstances when adverse events are committed in complex situations. Chronic patients, for example, diabetic with end-stage renal disease and infections, septicemia, and so on, coagulopathy. These are more like there is an encounter. At every encounter, there is a possibility of committing an error in such patients. Levels of uncertainty, that's early symptoms. A patient, for example, complaining of tiredness. There's need the expertise, actually, of experienced physicians. And it might be very difficult for the junior who is inexperienced to sort it out. In actual fact, it might be channeled to the wrong alley, ending in the wrong destination. Time pressures and fatigue, it goes without saying, is proportional. The errors are proportional, inversely proportional to fatigue and overload. Now, what are the main errors due to human factors? Cognitive psychology has identified the following factors as a cause of medical errors or adverse event. Sleeps. Sleeps is distraction during work. For example, a nurse is drawing 10 units of insulin to give it to a diabetic patient. Then there's a big bang or somebody shouting. Her attention is distracted. She draws 20 units, give it to the patient, hypoglycemia. The problem of sleeps, usually, they are not identified at the time of occurrence. But can we reduce sleeps? Yes, there are measures to be taken to improve the work environment which can substantially reduce sleeps. There is no time to go into details. Lapses. In lapses, for example, we have got a protocol, guideline, standard approach, but the doctor opted for some reason or another not to follow these standard guidelines or steps. So this is a question of supervision and accountability. Mistakes usually there is error of judgment because of lack of knowledge. And the remedy to this is actually training and supervision. Violations are very rare, whereby doctors opt, for example, to, like what's happened in the UK, terminate the life of patients with end-stage malignancies and so on, and this is a very rare occurrence. The blunt end, we said that the sharp end is where the professional expertise is applied, and this is our blunt end, where usually this is the start of the problem. This is what we call errors in waiting. Composition of policymakers, healthcare managers, and regulators are responsible of a long list which you know very well about the expenditure, overload, staffing and training, policies and procedures. A combination of several of these factors and at the end culminates in a problem occurring at the sharp end. Studies have shown that these factors are usually associated with catastrophes which have occurred in hospitals, problem of staffing, poor training, lack or absence of defective equipment, an environment of poor information, uncertainty and stress. Individual problems, I will just concentrate on risk perception, inexperience, training, all you know. Risk perception. The risk perception differs from one doctor to another. An example of that, for example, a staff nurse would come to the common room, informing the doctor that a patient post-op is bleeding. So one of the doctors will jump to his feet and run. Another will stay till he finishes his cup of tea or coffee. That's different risk perception. And the risk perception, actually we need to train ourselves to improve our risk perception. Risk perception has resulted in catastrophes. In our hospital, 2 months ago, very sad stories were told or circulated in some hospitals because, in my judgment, of a poor risk perception of the doctor. Psychological problems, well, some studies show that 30% of doctors and other healthcare workers have got an above threshold stress level. Well, as stress, well, memory is reduced, concentration is reduced, judgment is disturbed, tension rises, interpersonal relationships are strained and become difficult, and the whole environment becomes conducive of committing errors or poor judgment. Can we reduce stress level? It's a responsibility of healthcare organizations to do their utmost best to reduce stress level. That's by valuation and appreciation of medical staff. Provision of clarity. You're supposed to say that clarity is a problem in our healthcare organization. Either is absent, incomplete, or sometimes documents are contradictory or not implemented. Then we have to have a system of monitoring, supervision, and revalidation. I hope this is not happening. The darker side of the doctor. When autonomy can become arrogance. I'm sure it's not happening. Competence can lead to a sense of invulnerability. Application of science may develop into being simply obstructive. Collegiality may become a conspiracy of lies, of silence, to hide so many wrongdoings which are being committed. So, we have discussed the magnitude of the problem worldwide. What are what is the magnitude of the problem in the Sudan? A study was conducted by WHO Ministry of Health in the year 2005 from January to December. The main objective to determine the magnitude and preventability of adverse events in the Sudan. Adverse event was defined as disability, whether minimal or permanent disability, death or increased length of hospital stay. 6 hospitals were chosen. About 4,000 medical records were reviewed by 2 reviewers which were trained. First reviewer a nurse and a junior doctor, and second reviewer a senior doctor. And these are the results. The rate of adverse events in those hospitals, which were the best hospitals, and I think the best units, and this is one of the limitations of the study, that 5.5% of acute hospitalization develop or experience adverse events. The hospital range from 3.9 to 7.1. The adverse event rate slightly increased with age, from 4.2 for ages 15 to 29 to 7.6 for those above 65 and 5.3 for those below 15 years of age. The rate was slightly higher in males, 5.5%, and the rates were related to the discharge status. Those patients who died had a higher adverse event rate, about 38.7, while those transferred to another hospital had a rate of 10.8, and those who remained in the hospital had a rate lower than that. The distribution was even in all hospitals. Mainly, you can see this table, diagnostic errors, very high. Adverse events because of diagnostic errors. Operative incidents, adverse events regarding surgery of patient was very high, 26, and therapeutic errors lower at the end were 60 out of the 218 adverse events. So there are problem of diagnosis, problem in the surgery, and problem in medication. A rate of disability classified either minimal, less than 1 month, or moderate up to 12 months. More than 12 months classified as permanent disability. So minimum disability was 33%, and permanent disability 4.8%, death 34.6%. Some of them ended with permanent nursing care or in institutions. Preventability rate was 84.7%. This highly preventable episodes of adversity, 84% were highly preventable. The preventability did not differ statistically between hospitals. The highly preventable rate showed a decline with age. The rates were similar in males and females. Protocol and guidelines were identified as one of the main factors of adverse events. Don't know whether it's surprising or not. 71% of the errors were due to errors of omission rather than due to errors of commission. So I think this is a problem of training and possibly supervision as well.
Excuse me, 5 minutes left.
Okay. Again, preventability does not differ between hospitals. Surprising enough, adverse events, the high rate committed with ordinary common problems. 9% is hypertension, current medication 8.9%, diabetes 4.5%, and malaria 5.1%. 15%. So it's not a problem of complicated cases really. Okay, what can we do as a remedy? We mentioned that there are problems in diagnosis. So we have to improve our diagnostic process as individuals, as units and departments. This is done by enrolling, taking initiatives, individual needed, organization needed, and continuous professional development. Professionalism, currently there is a course, a three-day workshop course of professionalism run by the Sudan Medical Council for House Officers, Registrars and Consultants as well. Cover the three elements of professionalism, that's behavior, ethics and communication. There is a problem of communication within the health team, between health team and the interface of healthcare delivery as well. Risk management, now we have to go for effective management rather than management of patients, to go for effective management of patients, and that requires to adopt a system of risk management, even at the unit level. Of course, it would be better to be developed by the healthcare organization, but even you can start it at individual level or at department level. Healthcare organization, actually they are responsible of safeguarding the standards of care. And that's by creating an environment in which clinical excellence will flourish. And the best system to follow, actually to review our managerial system of clinical government, I think would be the best bet in these days. Scientific societies, again, I'm proud to say that this society, our Chest Physician Society, has taken the lead in developing STGs, standard treatment guidelines. We have developed standard treatment guidelines for pneumonia, one for bronchial asthma, protocol for bronchial asthma, and a policy for antibiotic for treating respiratory infection. So that's one of the prime responsibilities of scientific societies to improve the healthcare system. Ministry of Health responsible for strategies and policies. Sorry to say, these are not clear, sometimes not developed, not existent, or not implemented. So it has to be looked at seriously. A high-level expenditure is very difficult to safeguard the patient of safety unless we make sure that the necessary components, technologies are available. And I think with the present level of expenditure, that would prove inadequate. And at the same time, even with this low level of expenditure, the burden of expenditure of the healthcare lies with the individual, whereby 64% of health expenditure of the individual comes out of his pocket. This is just outlining and introducing the concept of health of patient safety. It's a quick run, trying to introduce the concept, highlight the problems, and persuade the audience to start embracing the concept within the everyday medical practice. Thank you very much, Mr. Chairman.
Thank you, Dr. Khatmi Jens, for this very informative talk. And
الإخوة والأخوات الحضور جميعا من مختلف المقامات السامقة والرفيعة، السلام عليكم ورحمة الله تعالى وبركاته. ويسعدني ويشرفني أن أكون يعني جزءا من هذا المجمع الكريم المهم في مسار الجمعية وفي مسار الطب في السودان، ألا وهو المؤتمر السنوي في المؤتمر العلمي السابع الاختصاصي الصدر السوداني. والشكر لكم انكم اتيتوا لي هذه الفرصه ان يعني اقدم هذا البرزنتيشن وهذه الورقه المهمه في تقديري في تاريخ السودان. The National Pulmonary Tuberculosis Prevalence Survey is the first to be conducted in Sudan. By way of introduction, I'm sure that you all know that TB is an infectious disease and that nearly 1/3 of the world's total population, about 2 billion people, are infected, and almost 2 million people die every year due to TB infection. But what you may not be aware of that Sudan takes 8% of the estimated TB burden in the Eastern Mediterranean region. And that in 2010, the estimated incidence of TB cases was 119 per 100,000 population, accounting to around 40,000 of TB cases and about 53% case detection rate. And maybe this is the most, this effort is directed and overseen by the National TB Control Program, which acts through 3 levels of organizations, with the main goal to reduce TB burden in Sudan, particularly among poor and vulnerable population, in line with 2015 MDE and Stop TB partnership. And the main rationale to conduct this survey, as I have mentioned, that the planning and monitoring efforts are based on an estimated TB prevalence rather than actual prevalence. And that in spite of the all efforts done and conducted by the National TB program, the incidence case detection is still under, they're still under notification. Also, the survey will reflect the actual situations that will be used to further enhance strategies that could increase the detection rate and will improve the proportion of TB cases being captured and then allow for earlier diagnosis and higher quality treatment. Also, the current TB situation, the estimated one, puts Sudan in Group 1, that is countries highly recommended to conduct TB survey, which will be used to have a baseline for monitor and evaluate the performance of the National TB program and also to measure progress towards MDG 6 for 2015. With this background, the survey was, the proposal for the survey was set with the main objective of to study the prevalence of bacteriologically confirmed pulmonary TB among the other population and specific objectives of to estimate the prevalence of smear-positive pulmonary TB, culture-positive pulmonary TB, radiological abnormalities suggestive of TB, and also to provide, as I have mentioned, a baseline for future measurement of trends in the burden of the disease. Also, we do have secondary objectives that to assess the healthcare, the health-seeking behavior among TB suspects and to estimate the prevalence of TB suspects in the community. And by TB suspects, we mean those who have cough 14 days or more or having abnormality suggestive of TB. Chest abnormality, chest X-ray abnormality. The methodology of this survey, it is a nationwide cross-section community-based survey. It will cover the 17 states and all locality using the 208 census, household census done by the Central Bureau of Statistics. And the inclusion criteria at the household level is that within the selected clusters or population administrative areas, all household units where households reside will be included in the survey, except households within institutional facilities, that is to say the hospitals, schools, prisons, and border houses. Also households within the diplomatic and military compounds. Unfortunately enough, this accepted population account for less than 5%, which is the international global standard for exclusion. inclusion criteria at the individual level will include all individuals from both sexes irrespective of their health status. That is to say, even if they are in TB treatment, currently having TB treatment will be part of the eligibles. And they should have an age of 15 or more years. They have to be resident in the selected household, and for visitors who will take those who spent at least 3 weeks before the census in the household. From this criteria, we reached to 114 clusters or population administrative unit, and 800 eligibles should be taken from these clusters, accounting for around 90,000 persons, and we will take these eligibles from around 100 to 250 households per cluster. The screening process is that all eligible survey population and eligibles who will capture them from a census form that it lists all the household members. Sorry, the form is in Arabic, with their sex and age, and from age we identify those who are eligible by the inclusion criteria, and then we will seek their residence also by the inclusion criteria, and from here we took those who are eligible for the survey. For all those who are eligible, we will take the demographic data in terms of relation to the household, head of the household, the marital status, from where do they come in terms of the states, and their education and occupation. And then we will identify whether they are present currently present during the visit to the household. If yes, we will continue to have their consent. If no, we'll give them a yellow card for the follow-up and move-up for them by the team leader. And when we ask for the consent, if they agree, we'll give for those who are present and agree a green card to continue with the survey. And those who refuse to be part of the survey, we give them a red card also for follow-up and to convince them to be part of the survey. Then all those who are eligible and consenting, we screen them by symptom screening form, and it is a very simple form asking about whether the individual have cough or not, and if having cough, for how long, and if they are currently on TB treatment or not. Then we will do a chest X-ray, and in the field we are using digital portable X-ray machines to screen the population for all those who are eligible. This screening is for all those who are eligible, that is to say the 800 per cluster. We screen them by symptom and we screen them by X-ray, and then we will take whether they had the X-ray or not. If they took the X-ray, whether it is normal or abnormal, and also from this screening process, we go to the eligibility for sputum. And those who are eligible for sputum should be either having abnormal chest X-ray or uninterpretable chest X-ray, or refused. Even those who are refused will take sample of sputum from them, and those who have cough for 14 days or more, and those also who are currently on TB will take a sample from sputum. And the sample of the sputum will be subjected to smear and culture assessment. And here is the flow in the field. This is just to show you how hectic is this survey. It starts by a pre-visit for the cluster by the state's officials before the team reaching the cluster. And in this survey visit, they will assess the accessibility, the feasibility of conducting the process there, the place for the team to reside, the number of households within the clusters in order for us to decide whether this cluster will consistent with the sampling process which select the clusters according to population size, and so on and so forth. At the end, they will fill a report for this pre-visit, which will be ready for the team when reaching the cluster to have their plan based on that. When the team reads the cluster, and by the way, the team is composed of a team leader, 3 interviewers, 2 technicians, X-ray technicians, and 2 lab technicians, medical engineer, and radiologist, guest physician, or medical officer, as you will see on the actual work that we are doing. In the protocol, it said that a radiologist should be part of the team, of the field team. Then, in the field, 2 interviewers will be separated to the households to have the agreement to fill the census form that I have showed you and to have the consent. All consented will go to a camp area or a camp study area where the X-ray and the lab and the rest of the process is positioned within the cluster. And there, they will fill the symptom screening and will have the chest X-ray, and based on the result of the symptom screening and the chest X-ray, they will decide whether they are eligible for sputum or not. If eligible for sputum, and we are expecting 10% of the 800 eligibles to be eligible for symptom screening, for sputum collection. If not, they go back to the reception area to finalize the process of filling the forms and then back to their home. It's worth mentioning that for the chest X-ray and for the quality check, we do have a central radiology unit whereby the chest X-ray images will send on daily basis to the central radiology unit, and double check of the results of the field will be done. And for the lab, also on daily basis, the sputum sample is sent to the National Reference Lab, here in Khartoum for the analysis of the sputum. This, in very brief, the process in the field. And we have conducted a pilot for that, carried in 2 states in 4 clusters, and the selection of the state is meant to inform the diversity of geographical location and context that will adequately inform the proper survey, and for sure the pilot clusters were selected out of the list of the chosen for the survey. And the main objective of the pilot survey is to assess the feasibility of the suggested methodology for the survey in the actual Sudan context. And the specific objective is that to estimate the eligibles per household and the response rate at the household level, at the survey level for the survey, and X-ray and sputum. Unfortunately enough, we do have a very high response rate for the 2 bullets in the field, and also to test the X-ray machines at the field level. And here was the challenge that we have faced. As I have mentioned, we are using a portable digital X-ray, and unfortunately these machines was the first to be used in Sudan, and when we got to the field, we felt that these machines have a problem with the heat. So the temperature rises soon after they started working with them, and they stopped for almost half to 1 hour, which delays the process. In the protocol, we are estimating to have 150 images per day, and based on that, we put the timeline for the survey that we will spend in the cluster only 10 days. Unfortunately, during the pilot, we have spent from 19 to 22 days in the cluster to have the target eligibles. And here is the main problem. Also, in the pilot, we use medical officers as a reader for the chest X-ray in the field. And unfortunately, also, the central panel result is that the quality is not that needed to the standard, so we need to stick to the original protocol that came from the WHO that we should use a radiologist for the field. Unfortunately,
5 minutes left.
No problem. Towards the end. Also, to test the survey tools, that they were good, and to test the feasibility of transferring the sputum, we don't have a problem. To assess the time needed, as I have mentioned, it is doubled after the pilot, because we are estimating 10 days per cluster, and we end by 19 per cluster. The logistics and the effectiveness of the volunteers, there is no problem. And the main recommendations from the pilot is that we need more X-ray machines in order for us to capture with time because it is a prevalence survey. It has to be conducted in 2030. And fortunately enough, we do have this agreement with the UNDP. Now we are start procurement of additional 4 X-rays to activate the process of the survey in order for us to end in 2030. And also we ask for additional budget to overcome the issue of the added logistics, human resources, and extra time. And by human resources, I mean that the issue of the X-ray machine being having problem in the field, we add a medical engineer as part of the team field, which previously is not there. And the recommendation of replacing the medical doctor by a radiologist or case physician, in fact, also one of the issues that we anticipate an additional in the budget. Now we started the actual well in second week of February in 4 states. In Kasala, we actually finished 2 clusters, and now we are working in the 3rd. One in Blue Nile and Gadar just started, and 4 clusters in Khartoum State, 3 finished and 1 just started. The survey, as I have mentioned, should continue till December 2013 because of we are guarded by the number of portable X-rays, so it is not a cross section as the household that you conduct throughout the 17 states in the same time. So it built on. The most important point that I need your support, and in fact it is the only point that نقول بالعربي التي سنؤتى من قبلها هي الحته بتاعت الجست X-ray. Still we are facing the challenge of having committed radiologists or chest physicians working in the field. And in fact, now I do have 2 states. Still we are back working with the medical officers who are not having enough training in chest X-rays because there is no radiologist, there is no chest physician to cover. والحكايه دي يا جماعه خلونا نرجع نتكلم بالعربي. حقيقه هي اللي هتهزم السيرفي يعني. And we have done all our best يعني بانه to have radiologists or chest physician working in the field. Unfortunately, the response is very limited. And here, it's worth mentioning a real appreciation to those who are committed till now working with us, Dr. Luay, Dr. Salah in the field, and Dr. Muhammad Al-Baqir, and معلش يعني لو نسيت اسم هبة ذكريني من الإخوة اللي هم واقفين معانا since نعم عفاف ومايد السيد دكتور مايد السيد الراديولوجيست حقيقة هم they are supporting us very much لكن التحدي كبير يا جماعة. الآن أنا عندي 2 states الحكاية دي والجوبردايز الكواليتي اوف ذا سيرفي لأنه هو بيعتمد أساساً عشان أنا أصل للإليجيبل فور سبيوتم I have to do both the symptom screening and the chest X-ray. ولو ما لقيت chest X-ray أو حتى نحن الآن نازلين بمقترح إنه يدونا to have registrars working with us. وبالعدم يا جماعة ده بيقول لنا medical officers. يعني أنتم كلكم عارفين إنه medical officer will not be expert to the extent that can diagnose. وبعدين الدايجنوزس بالمناسبة في الفيلد احنا ما دايرين ريال دايجنوزس، احنا دايرينها اب نورمال ولا اب نورمال. السنتر البانل will detail the diagnosis. This is the last point. لكن I have to stress المعين يعني. احنا في الفيلد يا جماعة دايرين just normal ولا اب نورمال، وبالتالي يعني هذا نداء ومناشدة من وزارة الصحة يا جماعة. وبالمناسبة السيرفي ده كانوا عايزين يجيبوا لكم 4 كونسلتنتس من برا السودان، ونحن قلنا نحن لها في السودان هنشتغل. والآن كل التشالنجز has been resolved. بكل اللوجيستكس حاجات اللي أنا ذكرتها لكم، بكل الإشكالات المواجهانة except for reading of X-ray in the field. فأنا أتمنى إنه من هذا يعني الفورم يوجد لي حل، يا إما من الإخوة أنا أتمنى إنه أكيد هم موجودين يعني الإخوة في التدريب في مجلس التخصصات، حتى لو يعملوا لنا روتيشن للريجسترارز. الكلاستر الآن بياخد 2 weeks 15 يوم، نحن عملنا برضه ويضاف كل التشالنجز تو بريس التايم من 22 يوم ل 15 يوم. فالآن احنا يعني لو اديتونا ريجسترار في الستيتس والاصرار ده زي ما قلت هم they are directly supervised by the central panel headed by دكتورة مايدة السيد راديولوجيست مع دكتور محمد الباغل ودكتورة عفاف، الشكر لهم. هم بيعملوا تشيك وبالتالي الاصرار ده بيكون under training، وبرضه it is a good training for him or her to be part of such a national survey. وبعد نهاية الحكاية دي أنا am ready to sit with those who are concerned عشان ترزولف المشكلة دي. الآن أنا عندي ولايتين عندهم جاب، بعدين لهم 4 يوم وما عندي باك اب في الحتة بتاعت الإكس راي. والسلام عليكم.